the clarification that I am a gynecologist. Starting without further ado, so so as you can see from the ultrasound, we can diagnose all the following endometriosis. So we divide into superficial or intraperitoneal and the deep or the retroperitoneal. So in the superficial, we have the ovarian and the uterine, the adenomyosis, and deep we have all the parametrial endometriosis, the peritoneal endometriosis, bowel, bladder, and the uretry. Okay, so we'll start with the ovarian endometriosis. Ovarian endometriosis is the most common pelvic endometriosis which we see. It's a homogeneous cystic structure with low-level echoes, ground glass echogenicity. Ovarian endometriosis, as we all know, has been very much researched and thoroughly investigated, and all the features like site, the number, you have to mention it is unilocular or a multilocular, and one more feature which I would like to add is you need to know the volume of the cyst. So why the volume? Because especially at our unit we have started doing something called as ethanol sclerotherapy. So in ethanol sclerotherapy, when we have, as you can see in the next slide, you can see there is this unilocular cyst with no other deep endometriosis, with good AFC, with no other pathologies. You can do this therapy, and so the volume of the cyst will tell you how much ethanol needs to be injected in that cyst. The fourth is the sliding sign test. I will come to the sliding sign test a bit later. You need to put a Doppler on every endometriotic cyst to assess the vascularity. Of course, endometriotic cysts are not known to be malignant, but yes, sometimes there are 1 to 2% chance of it being malignant. So always put a Doppler on the cyst. So as again, rule out any malignancies. One more thing is, people often say that ovarian endometriotic cyst is an individual phenomenon. No, there are chances of deep endometriosis occurring, and in our studies we have seen that for a single cyst it is around 50 to 60% and around 90% chance of deep endometriosis happening if the patient has bilateral endometriotic cysts. We are now having so many patients who have endometriotic cyst, but inside the laparoscopy we do see other features of ovarian abscess. Now, differentiating a cyst from an abscess is very difficult. You have to correlate with the clinical symptoms if the patient does have that fever, and there may be some non-homogeneous appearance of cyst with no clear boundaries. If you see that, that should be a suspicion for ovarian abscess while doing the surgery. So as you can see, it's a unilocular, the multilocular, and hematosalpinx. So of course, we can see the tubal pathologies, hydrosalpinx, and the hematosalpinx too. Okay, coming to the adenomyosis. Adenomyosis, basically it is divided into three parts. We have the diffuse adenomyosis, where all the walls of the uterus, anterior, posterior, and lateral are involved. You have something called as focal adenomyosis of the outer metrium, and acute, which is accessory cavitated uterine mass. In the diffuse criteria, we do something called as an adenomyosis mapping. Now, what is it? So the first, we locate the dimension and the location within the uterus. You have to report the lateral and the inferior extension of for cases where we have to do microwave ablation and also adenomyoectomy. So we do it in two sections. First, we put a sagittal section. We locate the endometrium. We measure from endometrium, posterior endometrial border to the posterior border, likewise the fundus and the anterior. And also you can just rotate your probe transversely and you can measure the lateral distances and give exact mapping or exact adenomyosis in 5 dimensions. So that will also give you a volume of the adenomyosis in relation to the whole uterus. Of course, now people are more looking into endomyometrial junction or the EMJ zone. EMJ zone is also visible very good in transvaginal sonography. Of course, much better in MRI, but even a good 2D or 3D can give you very good EMJ zone. And of course, you need to rule out deep endometriosis also for diffuse adenomyosis, as there is very high chance of adenomyosis in such cases. We all know the characteristics of adenomyosis: asymmetrical thickening with cysts and fan-shaped shadowing. These are all the general features, and translesional vascularity, which differentiates from a fibroid. can see this adenomyosis, how it looks like, a generalized picture. Talking about the focal adenomyoma, for focal adenomyoma and accumes, you should provide the exact site of where that FAOM is located, and sometimes it could turn out to be a degenerated fibroid. So the vascularity point works here. You put a vascularity on the fibroid, you will always get a peripheral vascularity rather than a translesional vascularity. You should always report the number of FAOM and accumes, because the treatment for this is somewhat different from a generalized adenomyomectomy, or because in such cases you can also do a microwave ablation. And yes, one more point, we are also getting recent cases of operated cases of adenomyomectomy and our microwave ablation, who the radiologist people are not very much aware of how to do this. And so any recent myomectomy or adenomyomectomy can also look like accumes, and they are very much wrongly diagnosed as FAOMs and accumes, and they come to us and we do a re-diagnosis, and we give them that this is not a acum and FAOM, it is just past surgical findings. So this is how an acum looks like. You can see a very well circumscribed endometrial collection. Okay. You can see it is very well differentiated from the endometrium. The endometrium is on the left. Okay. So such acums can be very well managed with microwave ablation, and for that USG guided microwave ablation works beautifully. This is focal adenomyoma of the outer myometrium. Now, why it should be differentiated from a diffuse adenomyosis? Because here you can see the EM junction and the endometrium is very beautifully maintained. So in such cases, if you are someone who is doing microwave ablation rather than adenomyomectomy, this FAOM will, the treatment for it will work very beautifully, because you are far away from the endometrium and there is no way you can damage the endometrium. Okay, so something about the IDEA consensus. It is the International Deep Endometriosis Group that projected a guideline on how to do a mapping. So the first step is you do a routine evaluation of the uterus, bilateral adnexa. Then the second step, you go for deep endometriosis and do the sliding sand test. The third step, you evaluate the D in all the compartments. Just two addendums they have added in recently. So something called as peritoneal endometriosis, superficial peritoneal endometriosis, which I will talk about it, and also about parametrial endometriosis. These 2 points they have added recently. So yes. So coming to the dynamic test of sonography. Now the first test is a sliding test. Sliding test is a test which is a very basic test which can be done on any two structures transvaginally. You have to just put the probe, you centralize those two structures. It could be ovary, it could be the uterus, it could be the rectum, it could be anything. You just push in between both the structures. If both the structures are moving away, it's a positive sliding sign. A positive sliding sign means that there are no additions and it is a good thing. A negative sliding sign means that the structures are adherent to each other and there must be some pathology causing it. So that is it about sliding sand test. Sliding sand test can be done on any two structures. Okay, it is not just of uterus or the rectum. And other is a probe tenderness or the site-specific tenderness. Now these two tests make the transvaginal sonography superior to an MRI because this can't be done in an MRI. Probe tenderness, you put the probe in the fornix, you tell the patient that you may feel some kind of pain in the anterior fornix or the posterior fornix, and you ask the patient to let you know that where that pain is occurring, because if you locate that site, most probably that will be the point where the deep endometriosis will be located. Okay, so pre-procedural counseling is very important in such cases, especially for women who are unmarried or who have, even we are having cases who have vaginismus, because these people think that the vaginismus is a part of the endometriosis, but the mid-vaginal vaginismus which occurs is not because of the endometriosis, because once we pass through that in the posterior fornix, these patients are quite comfortable. So that rules out that it is not due to the endometriosis. So you can see the sliding sand test. This is for a retroverted uterus, where I have put the probe in the posterior vaginal fornix. As you can see, the POD is free and both the structures are moving away. This is the ovarian sliding sign. You can see the ovary and the sigmoid colon, they are going away from each other. So it's a positive sliding sign. Okay. So now the posterior parametrium. So according to idea, uterosacral ligament, the prerectal space, and everything has been converted to one terminology, that is posterior parametrium. They don't differentiate now. They say rectovaginal septum, uterosacral ligaments, and peritoneum is all a part of the posterior parametrium and have to be reported as such. Okay, it should be done in a prepared bowel. Now there are two main findings of the uterosacral endometriosis. One is that the uterosacral can be, as you can see, can be seen like this white line in a sagittal section. It starts from the cervix, and there is a, if you put your probe in the posterior fornix at the 45-degree angle, you will see these both uterosacral ligaments. In endometriosis, there is a thickening of this white line, and the thickening is like, if you, in general terms, there is 4, 5. Okay. Um, so there is this hyperechoic thickening. That is the first sign of starting peritoneal endometriosis. Of course, any kind of hypoechogenicity, if noted, it's a nodule. Okay. The sliding side test and the probe tenderness also helps in the location. And this is something new. So what is sonopodography? So we all do SSG for our fallopian tube patency test. So now what they are saying this, it has been recently very popularized by one Dr. Mehta, who is a very big name in Hyderabad, and she does routinely. I also started doing it. And of course, there's one guy, Matthew Leonardi. He's also a very good gynecologist and surgeon himself. So what it's very simple. You do an SSG. You already know that your tubes are patent, and you make make the patient walk for some time. After 15-20 minutes, you will see that there is this fluid collection in the POD. Now that fluid collection will act as your contrast gel, or it will make that distended, and you can see all the peritoneum. You can see the uterosacral. You can even see the rectal serosa, and all very small hypoechoic dots or nodules can be easily picked up. So this is very good for diagnosing something called as superficial endometriosis. And as someone was telling, for now we have so many patients who have chronic pelvic pain, but there is no diagnosis for it. So you can try this sonopodography, and it has worked for us actually. We have diagnosed 2 to 3 patients by doing this. Okay, so this is the idea consensus statement. They hired like 200, 300 gynecologists to do the sonography, and there is an opinion. Yes, TVS is very good for predicting of the posterior parametrium. So there is no need of doing an MRI. You can very well, with good training, you can 70 to 80% participants have agreed on that, and I too agree on that. So this is how the USL looks on a sagittal and a transverse view. Okay, so you can see on the right, as I said, this is the nodule. This is the uterosacral ligament. This is the uterus here. So this is a definite nodule, this one. Okay, hyperechoic. You can see this white structure. If there is white, it is thickened. Okay. This is actually a case where there is this parametrial endometriosis, and the parametrium, deep endometriosis of the posterior parametrium, and you can see the ureter. So it is a myth that the ureter cannot be seen on transvaginal sonography. If you are trained, you can very easily see the ureter at the level of the ovaries and even at the level of the bladder. And you can see this hydroureter. It was around 7 millimeters. This is the artery. If you put Doppler, the Doppler will shine on this. The ureter won't take up Doppler. So that is the sign. And there was clear hydroureters which were diagnosed on transvaginal sonography. Okay, so coming to the bowel endometriosis, everyone's favorite. Rectal and sigmoid colon endometriosis should be done in a prepared bowel, and we know it looks like a hyperechoic bag, irregular thickenings, and usually it is a part of a larger nodule arising from the uterus, from the cervix or vagina, we have that, but isolated bowel endometriosis have been reported where there is just a bowel endometriosis on nothing else. It is not even adherent to anything. Okay. Now that are cases which are quite difficult. Location, number, and dimensions have to be reported correctly in order to prepare a plan of treatment. Now, this is a criteria for something called as stenosing bowel nodule, meaning in what cases of bowel nodule would you require to do something very radical like cut, resection and anastomosis. So the rule is very simple. You do a transverse imaging of that nodule, and if the depth is greater than 10 millimeters, there is no second thinking. You have to resect that bowel. Okay. Of course, there are 6, 7, 8 millimeters, but that can be done under a discoid or even a deep rectal shaving will work for them. Okay, the width of the nodule greater than 30-40% of the bowel circumference. So yeah, so how to do that bowel circumference? So you take a transverse section of that nodule, you measure transverse diameter, meaning that nodule should be measured in the transverse, and then you take the total circumference of the loop. You will see a rectal loop. You measure it like this, and you just divide both of them. So if it is greater than 30 to 40% of the bowel circumference, so that will require to do a resection and anastomosis. However, this is much important. Greater than 10 millimeters, no need to go further here and just do it. This is to be done only and only if there is a large plaque, like that the plaque of the nodule is around 5-6 centimeters, and you want to know whether because the plaque will be large, the depth would be around 7 to 8 millimeters borderline. So you will be confused what to do then. Then this will give you a better idea. So IDEA also agrees on it, and it has said it is recommended to detect the presence on rectum. Less accurate for, of course, sigmoidal. Sigmoidal is something which is very difficult. And my opinion is absolutely you should be knowing diagnose rectum endometriosis on transvaginal sonography. It's one should not miss a bowel nodule on TVS. Anything can be missed, but a bowel nodule should not be missed. These are the normal layers of the rectum. You can see the serosa, the anterior muscularis. Okay, this is the lumen. This. Okay, anterior, this is the submucosal layer, posterior submucosal, the posterior muscularis, and the serosa. So this is how a normal rectum looks. Okay, now this figure is important. So we have got the nodule, but how to in the MRI they give that it is 15 centimeters, 20 centimeters from the anal verge. So there is a predictive criteria for diagnosis. So it's quite simple. This is the cervical internal os. This is the torus. If there is a nodule at the torus, it's an intraperitoneal nodule. Because as we know, the peritoneum covers here the POD. So everything lower down the POD will be lower rectal retroperitoneal. Now why is it important? Because low rectal resection will require a multidisciplinary approach, and the prognosis is very prolonged for such patients. And anything above this is intraperitoneal. So if you see a nodule at the fundus, it may be upper rectal. At the back of the uterus, at the torus, it will be mostly mid-rectal. So this gives an idea about if the resection margins and the prognosis. Okay. So you can see, this is the bowel nodule. Okay. I think there are all these signs of red Indian hairdresser sign and antlers, moose antler sign. It is nothing but, as you can see, this irregularities of the submucosa. You can see that white lines coming into the hypoechoic nodule. So that means that the submucosal layer is inward, and that will require resection. These white lines you can see. So this is all the moose antler sign and the red Indian sign, just complicating a very simple thing. Yeah. Okay. This is a double bowel nodule. You can see there is this bowel nodule here. This is being demonstrated by Jay sir. You can see. So this is the lower rectal nodule, and as we go up now, we will see a different bowel nodule here. Okay. We did a double discoid excision for this patient. You can see two separate nodules. If these are very close to each other, you need to mention the distance between them, because some surgeons also prefer to resect those nodules in one segment. Okay. Now this is something called as a loop on a loop syndrome. You can see, if we see very closely, you can see just one nodule adherent to the uterus here, okay? But if you see, this muscularis is going like this, then it is turning back like this, then it is going like this and turning back like this. So the two loops of the rectum have gone adherent. So this, when you unloop them, it will become like a 4-5 centimeters rectum, and that might require a resection. So this is very important, because from the picture you can see, okay, yeah, it's just a 4 centimeter complete, I can do a shaving. But when you go inside, you will see that it was a loop on loop, and when you open it, you have to resect it. So a loop on loop has to be mentioned. So this case we had from Kolkata. You can see this the whole black thing. It's the whole nodule. Right from it's starting from the vagina, and you can see the fundus is ending. This is the uterus, and it is going till above the fundus. So it was covering the whole rectum, mid rectum, and the lower rectum. Around, you can see that distance is 8.1 centimeters. It definitely requires the whole 9 to 10 centimeters ball had to be resected in this. You can see I have measured the depth. Yeah. Okay. Now coming to the anterior parametrium. Anterior parametrium, most common is the bladder endometriosis, dysuria and everything, long standing of most bladder base adjacent to the vesicouterine pouch, trigone, and the bladder dome. It can be seen as a hyperechoic nodule with regular margins and, of course, Doppler positivity. You can obliteration of the vesicouterine space, also called the anterior parametrium. So you can also do the sliding sign here. You can just put your in the anterior fornix, bladder, uterus, and you push the bladder. If they go separate ways, that is it. This test is very useful for even diagnosing when there is the previous 2-3 cesareans, and if the adhesions are present on the anterior abdominal wall or not. Okay. There is a place of transabdominal sonography in bladder, because what you can do is you can just put a probe and you can delineate the bilateral ureteric orifice. It's nothing complicated, just simple. Just wait. You put a Doppler window on it and you just wait. You will see these ureteric jets beautifully coming from below. And you, of course, if you see the nodule and if you see the ureteric jets, you are very damn sure that it is at the level of the tricone. And if you are not able to see that the ureteric orifices and the nodule are different, you can be very sure that the trigonal is not involved. And the idea also agrees that, yeah, DE10 of bladder should be diagnosed on sonography. Okay. So again, similar picture. Okay. So if you see at the bladder, at the point here, it is at the bladder base. Just below it, if it is surrounding the vagina, it is more towards the trigone. And you have the bladder dome here. Of course, bladder endometriosis is something which you can very easily diagnose by cystoscopy, but a pre-surgical diagnosis will actually help in just predicting what you are expecting inside. So this is the bladder endometriosis. You can see this was the trigonal endometriosis. Of course, so what the guidelines suggest is bladder should be looked at the last in your examination, because what happens when you are doing it for 15-20 minutes, the bladder will fill up, and that is the best time you can diagnose any kind of bladder endometriosis. You can see this ureteric jet coming, and this is the nodule. So if they are both seen in the same plane, you can very well diagnose it as trigonal endometriosis.
Dr. Vismay, 2 minutes more.
Ureters and kidneys, we all know, most common site. And this is the video. For the case which I showed for hydroureter. Okay, we know the grading of hydronephrosis, severe, moderate, and this is just a short point on the lateral parametrium. Lateral parametrium is just 1 to 2 points. Hyperechoic nodules and irregularities are seen. Compared to any other parametrium, diagnosis of lateral parametrium is very difficult even on sonography, because even the CT and MRI are very non-specific on it. Unfortunately, still lateral parametrial is gold standard, is laparoscopy. Okay, they have added an addendum to how to diagnose it, but still you can see this black structure here and all the vessels here. Okay, and this is the nodule here. Now to pick it up is quite difficult because there is no landmark here. You are just looking at an empty space and trying to find out something. And sacral plexus endometriosis is something which is upcoming. I have seen, well, it requires a bit of a concentration to do it, but you can see the sacral plexus fibers beside the cervix. Very difficult, not seen in all cases. But there are studies coming up. They're like this nodule I diagnosed recently in the lateral pelvic wall. Here, the bones and the piriformis muscles come here. So it is very, very lateral to the USA. You go very lateral to the uterosacrals. Essentially, you are looking at empty spaces. There is no landmark here. So you can be very well diagnosing something which is non-specific. And it very well could turn out to be negative laparoscopy. There are classifications NCN, AAGL, AFI. The idea is they say that NCN classification is good. NCN, just few points. So they divide it into A, B, C, F, and there is this gradings. So my personal opinion is, and even Mehta madam and all the speakers have mentioned that the NCN classification is only food for the insurance companies, because in America, as you know, in the foreign countries, they need something classification for the insurance. Me and Mehta madam actually give a very descriptive, and we can also draw the picture of how the adenomyosis and everything looks like, and that really gives an understanding of the disease to the doctor and also to the patient. But just one point, TVS performed by adequately trained operators is the first line imaging tool. First line imaging for deep endometriosis due to its availability, cost efficacy, and low environmental impact. I'm not telling it's the DOC, it is the first line imaging at least. Pros I've already mentioned. We only do ultrasound evaluations for our patients at our center. We do for those, even if we have done the patient have done an MRI, sir is so kind to refer to me for all patients for ultrasound evaluation. Cons, of course, they, not for young girls and unmarried women who are not allowing to do a transvaginal sonography. And yes, learning curve is associated with evaluation that needs to be overcome with proper training. And yes, there is a lot of material available online. And if you are starting a center for advanced laparoscopy and endometriosis clinic, ultrasound is a must. It is a modality you cannot miss. So thank you to my teacher, and the person who is present here is my everything. He has taught me everything here. Thank you.